Perfect. Okay. So good morning, everyone. I am very happy to introduce Dr. Veronica Smith, who is a professor of psychological studies and education in the Faculty of Education at the University of Alberta. Lots of education in there. And her co-presenting partner, Michaela Jelen, who is a doctoral candidate in psychological studies and education at the University of Alberta, as well as being an early intervention provider in British Columbia, Canada. So without further ado, please take it away.
Great. Thank you, Lori, for inviting us today. And thanks everyone for getting up early in the morning and showing up, organizing your children and families. So I just wondered if I could start. I can see a couple of people who are in the room. I wonder if you could just pop in the chat what your main vocation is. What's your main job? So that I can kind of have an idea of how many of you are practitioners, early interventionists, how many researchers, administrators, that kind of thing. Okay, oh, great. Great, oh, great. Okay, that is super useful. Great. Okay, good. So that is helpful. Okay, so I'm going to describe one arm of a project that I was involved with from 2017 to 2020. And that will be followed by a brief presentation by Michaela, who is sort of following up on this research for her dissertation. Okay, so just a few acknowledgements at the front end. This project was conducted on the traditional, ancestral, and unceded territories of many First Nations in British Columbia, but I wanted to acknowledge that where I'm working is in Treaty 6 territory. And these, in this territory, these were my three RAs who helped me with some of the data coding and discussion around some of the themes that emerged. And there was a very large team of individuals who participated in the project as researchers and as coach trainers. So I'm just going to let you look at them here because I have lots to present, but they were really from all over. We had some from the US, Wendy Younger at the Hospital for Sick Children, who did a cost analysis that I won't be referring to today, Pat Miranda and Paula Colazzo, who are at UBC. Actually, Pat is now emeritus, and 3 coach trainers on the project. So the background on this project really comes from things that we are all pretty aware of, the research suggesting that early intervention can result in positive and meaningful development for children with autism. These 3 citations that I have at the bottom are actually systematic reviews that were published post-study or during the study, and they each actually tell a little bit of a different story about early intervention and its impact. The first one by Sandbach that was published in 2020 actually divides up the type of early intervention. And it found that there were really 2 types of interventions that have more evidence for kids with autism: developmental and this new in early intervention called naturalistic developmental behavioral interventions, NDBIs. But Kaiser and Fuller, in their systematic review, they actually sort of asked a different question of the data. Does it matter who is the interventionist in early intervention. And they found, when they looked at all of the sort of the same studies that Sandbach had looked at, that the effect sizes were much larger for trained clinicians than they were for parents. Or they actually had preschool teachers in there as well. So they found this large effect size, and it was significantly different. Well, actually, it wasn't large, it was a medium effect size, and that was just for the professionals that were trained. NIMUS, that was another systematic review. They just looked at community interventions, early interventions, and the effect sizes that they found, so the impact of the interventions, were quite a bit lower than were found by early intervention efforts that were conducted by researchers or clinicians that were trained by researchers. So yes, early intervention, but with some caveats. That's what that research really reveals. But before that happened, there was this paper which really kind of shifted things that were going on in the autism literature. In 2015, Laura Shribman and a number of early interventionists published this article that recognized and named this thing called naturalistic developmental behavior interventions, NDBIs. And it was really an integration of applied behavior analysis and developmental science. And what they recognized is that a lot of the interventions that, so the Early Start Denver model, the Jasper model, Amy Weatherby's early developmental intervention, they had a lot of similar traits. So their essential features were really quite similar. That caught the attention of the BC government, and they were very interested in conducting a study in BC and to train up early interventionists in the province in an NDBI and to serve kids that were very, very young, that weren't getting served in the province as frequently as other kids. But they wanted a lot from this funding that they were offering. They wanted, or what we found when we put our proposal together, was that there was no real surveillance system in the province to identify very young children with autism. So that was sort of problem number one. And there were really, across the province, very few clinicians. I have my dog at the office. Just hang on. This is my child. Everyone else. Okay. And so we needed to train up the clinicians, and we also knew that each community was serving families in very different ways. So we were successful in applying for this project, and we had 3 years to pull off a lot of things: the screening system, the training, and an actual study to look at the effectiveness of this early intervention. So our basic plan was to recruit agencies in every region in BC, to train the early interventionists in 2 models. And the NDBI that we chose was the Early Start Denver model. And the reason why we chose that was because we had 3 clinical certified trainers in the province. Because with this, we wanted this to be a community implementation of early intervention. We also developed a system to screen young children at risk for autism, and developed also a couple of studies to look at the impact and cost of our trained community partners in implementing this NDBI through parent coaching. Oh, sorry. The other model that we trained them in was parent coaching. So they had 2 different types of trainings. The process of getting effective programs to children who need them is really not all that well understood, but a lot of people have been doing research in this area. There's some big translational gaps in figuring out how to go about implementing best practices in community settings. So one of our research aims, really beyond the training and the screening, was to identify these promising practices to optimize future implementation of what we now, at this point, once we had the funding, we called it the PACE coaching project, Parent and Child Early Coaching. So the study of implementation, which is one of my areas of interest, has really been undertaken in earnest somewhat recently, actually. We know from implementation research that a practice must be usable, and by usable, it must have good fit and feasibility. Fit refers to how well the intervention fits with the program's values or missions, the current things that are going on in their centers, their priorities, their structures, and their community values. And feasibility really refers to the program's capacity and resources for implementing the intervention. And the practice really has to have clearly delineated, teachable, learnable, and doable practices. That are even measurable, so that the it of the intervention is trackable. Factors within the context can serve to support or put up barriers for an effective implementation. So these factors include the people who implement it, their attitudes and beliefs about the program, leadership, resources, and acceptability of the practices. And the third area, these change processes, really refers to the degree to which the participants are engaged in the process. So do they have advance notice of planning? Are all the processes really transparent in regard to how the project or the intervention, the innovation, is going to be rolled out in their community? So these are some of the key pieces that we have emerged from the implementation science literature. So what our intent was for this arm of the study was really twofold. We wanted to learn about the local conditions or any barriers and challenges that our participants might face in rolling out the project. We wanted to also, at the same time, be responsive to what we heard from our community partners. This aim, this number one aim, didn't really go unnoticed by our participants. One of our very astute coach trainees put it this way. She said, it's like we are still building the car while we're being asked to drive it, because we really were figuring out how we were going to do this as we were engaging with our community partners. Our second aim was to describe the conditions and context that might support future implementation of the PACE project. Okay, so what I wanted to describe for you today were 2 implementation frameworks that we used. The first one comes from the National Implementation Research Network, NIRN, and I know that many of you are familiar with this. I've actually taken course at the Glen Rose, for example, on about this, so I can see Lori smiling. People know about this. And the other framework that I used, which was mainly used to analyze the data, is the Consolidated Framework for Implementation Research, the CFIR. Everything has an acronym. So this is the NIRN stages of implementation framework. At the first stage is the exploration stage, and it preceded the training and the actual use of the parenting intervention with the families. The one thing that I need to say about this stages of implementation, although the figure depicts the stages as linear and sequential, they're actually really iterative and often overlap. For example, aspects of the training actually really continued all the way through the project because the trainees had access to the coach trainers all the way through. So all 4 stages of implementation are important in achieving high quality implementation. We met with our community partners first. We engaged in training as we prepared them to implement. And then at stage 3, the trainees delivered coaching to the families. And we really never got to stage 4, but we were hopeful of that. Wasn't really built into the project. So to collect data about what was going on in the project, we collected different data at each stage. Initially, we started off with a survey to better understand the context and some demographic information about the community partners and who was going to participate. After we collected that, we actually also did a focus group in each of the settings. And after the training, we did a few more surveys with the trainees. How motivated were they to actually conduct the implementation after the training? And then we conducted individual interviews with the coach trainers and actually the people who had been selected in the community to do the screening. And finally, at the end, we did another survey and a focus group in each of the settings. This final focus group co-occurred with COVID, so many of those focus groups were held online. Okay, so this is what we did at stage 1, meeting with our community partners. This is where the second framework comes in, because I used this consolidated framework for implementation research to analyze and code the data. This is really a very nifty tool. I have put down the URL below. This was work that was gathered, I think, by Laura Damschroder, and I know it's a framework that's been used in Alberta. In fact, I think I took a course down at the U of C on the CFIR around the time that this project was starting. CFIR has 39 constructs across 5 domains. It codes participants' perception of how do they feel about the intervention. Is this better than what you're already doing? How complex do you perceive the intervention? It codes aspects of the inner setting where the intervention is being conducted and the outer setting, the influences in the community that might impact the intervention. Also codes for aspects of the characteristics of the people that are participating, their own individual beliefs and values, and then also aspects of the process of implementing the intervention. even though these 39 constructs were actually consolidated across the implementation literature, and not all of them are relevant to every innovation, but I really did find this a very useful framework to code the data. Now, in saying that, I'm actually going to collapse. I'm not going to report on all 5. 2 of the constructs, the innovation characteristics and the individual characteristics, are impressions of whether or not it was a usable practice. Was it an enabling context, inner and outer setting? And then the change process, that was the 5th dimension. So I've sort of collapsed some of them here. So at the exploration stage, we found that the survey really helped us understand the agencies. Areas of strength included their organizational culture. People felt that they were working in an organization that made a difference, and they really felt very, very connected to one another. And there was a sense that there was strong leadership in these organizations. On the other hand, they were a little bit tentative about the intervention. They wondered whether or not it would be a good fit for their families. They had heavy caseload demands, and there was really low service to 18 to 36-month-olds who were the target of our intervention. And importantly, they had low or very little access or use of technology. Our training relied on the use of technology. Our trainers were on Vancouver Island, and we were using Zoom-like things to do the training. And I have to stress that this was pre-COVID, and what was going on in the real world was not even anywhere near what we're doing today. So there was a lot of training support around technology. So we responded to what we found in the exploration stage by organizing the trainees into pods. We felt that they could work together in their communities also to figure out problems. This was one of the suggestions that Sally Rogers provided for us. We put dedicated support into technology learning, but it still presented many, many problems as we progressed. We provided the centers with kind of local and regional support around advertisements to encourage family recruitment. And we also, it was a well-funded project. We were able to reimburse the agencies who participated and provide them with support for administrative costs and support to families for childcare and mileage. And we also developed a really informative communication about project activities to share all the various arms of the project in a newsletter that went out monthly. So in the preparation stage where we were engaged in training, we had 2 types of training. One were for the coaches, and one was for the screening, the surveillance system, or the screening system that we were implementing as well. And I will just tell you that there are a couple of articles that have been published in JAD that describe the training, or one article that describes the training in more detail. I'm not going to go into that in depth here. After the training was conducted, the coaches particularly they felt that they had this personal high quality training, and felt that it was really aligned with what they wanted to do to empower the parents in their communities. They really valued the approach, and they actually felt like they had new skills as professionals. They they felt that where they were working really supported the training, and the pods provided a great context for change. However, the training was the interventions, because there were two, they had to learn ESDM and parent coaching, highly complex, and they had concerns about how adaptable it would be for their families. It was time intensive. Technology presented problems all the way through. And despite our communique that went out monthly, they sort of sometimes felt like they had a lack of the big picture of the project. They didn't always know what was going on. We also learned that we had quite a variability with the coaches that were being trained. They were at much different levels of readiness for change. Some of them were buying in completely, others were not so keen. And I'll just actually, this is one of the leadership at Vancouver Island Health, and she comments a little bit about the training.
Well, I think one of the strongest features of the PACE project was the training for our coaches, our therapists, to be able to get feedback on their opportunities to share with families, to be able to get that kind of immediate feedback and advice on how they could improve, where they really excelled. I see that as being quite unique in this project. Many therapists over the years will take training, and you'll come away from training and you'll think, oh, that was so great, and I'd like to try that. And then real life happens, and you have a huge caseload, very full days, especially when you add in, other things going on in the world. And so it's hard sometimes to bring that training to life. Whereas in this project, the coaches, the master coaches provided such amazing individualized, personalized support to the therapists that they really did feel empowered as more competent and confident.
Yeah, so a tremendous endorsement for the training that was received in service. And I have to stress that it is super unique for people that are in service to receive this level of training. Typically, how we update our skills are through workshops, professional development activities, maybe over a weekend or a few days. But this ongoing training that occurred over a whole year for these trainees was really something unique, as Denise describes there.
Well, I think one of the...
Oops, I better move her along. Screening training, again, was thorough. What we found there was a lot of autism hesitancy, not only among the community that we were trying to recruit, to try the intervention, but really among the therapists too. They actually served their families in kind of more gentle ways. They weren't always wanting to introduce the autism word immediately with their families. They really worked them into this after maybe they had developed strong relationships with them. So this screening ended up being a bit intrusive for some centers, some clinicians, some families. And again, here there was a real time constraint. Locating families quickly was really tough for many centers. So we did respond. We had continued support for the technology. And in some cases, we updated the technology. We bought new technology because even in 3 years, the technology got old. And couldn't be supported by the systems that we were using. We increased our supports for recruitment. We engaged some activities that was, instead of paper, posters, that kind of thing, we use social media, which is really how younger parents are communicating with each other. And we kept up these regular communications. But, in retrospect, as I look back on this project, couple of years out now, we really didn't respond as well as we could have to the rush, the very hurry up sort of sense of this project. They needed to get trained and hit the ground running in a very short period of time. And that theme really was resonated all the way through the project. And casualties, we started off with 39 trainees. There were only 31 trainees that completed the project. And 7 of the agencies that originally started also dropped. And we had big casualties with our Aboriginal. We had a very intentional reach out to our Aboriginal agencies, and most of them dropped out. So there were pieces that I think this very rushed and maybe a lack of cultural sensitivity that inhibited aspects of the project. So I think that those were casualties that we didn't pay attention to as much as we could have. We did also have time constraints ourselves in terms of the funding. So finally, in the final stage, the PACE coaches were trained and they delivered the intervention to families. And there is a publication on the outcomes of that intervention. After the intervention, we went back to the communities, did these focus groups or held them online. Again, there was a strong sense that the intervention was beneficial for families. And for many of the coaches, it was transformative. They were doing business in a new way. They had been very well trained in more expert models of providing service, and being coaches was really something that super resonated with them. They actually were able to really truly understand what family-centered practice was. And the interesting thing is, although families or the coaches were attracted initially to the ESDM, this kind of certification in an early intervention model, what really resonated with them more was this parent-coach practices, the practices that were associated with that. But they also said they needed more training. And caseload demands, that was a struggle to implement the project. Again, the thing that was really that resonated was the access to these expert coaches, the coach trainers, was super valuable.
Veronica, Cindy's asked a question about fidelity, if we had any fidelity measures.
Yes, we did. Oh, thanks, Michaela. Cindy, do you want to elaborate? We did. But okay, I'll just say yes. We had fidelity of the coaching. Is that what you meant, Cindy? Yes. Okay. So the coaches were asked to provide videos before the training, after the training, and after the implementation. And they are reported on in a publication in JAD. I think it appeared in 2021, or maybe it's in 2022. And what I can say, so we coded the videos. In fact, we had the various people code the videos. There was high variability in fidelity across the trainees. So, but I would invite you to read that article. I think the high variability, though, is important. There were some trainees, for example, at the end of the implementation who had 98% fidelity, and others who had 38% fidelity. So high variability in how they ended up understanding the intervention and their ability to implement it.
So I think something really
now,
important
but,
that we did in PACE was sort of building this.
Sorry, I'll just introduce Janet, who was another one of our coach trainers. And one of the things that we recognized was how valuable forming these communities of practice, these pods, and how that really helped the centers improve their fidelity.
This community of practice, and that was through the pods, and it was much easier for the centers who had multiple individuals participating in PACE, I think, to support each other and build a stronger community of practice within their centers. I think it was much harder, even with our pods, once we started the research piece, for some of the individuals who were more on their own in their center. They still had us, but I think it really is important when we're looking at how to move forward and build strong skills. It really is critical that we have colleagues to support each other and build this community of practice where we can continue to hone skills and support each other with maybe situations that are more complex with some of the families we work with.
Yeah, a really valuable contribution and a piece that really, I think, worked well.
So I think something really important.
I'm going to get rid of her. Okay, so our key implementation findings were that the program characteristic, it was a good value fit for the trainees and for the leadership in the centers. And they really felt that it was perceived as a relative advantage to business as usual. For the most part, it was a good fit with family needs, and we implemented it in a place that had good networks, good communication, and positive climates for change. The training model, particularly around the coaches, was transformative. And I'm actually going to skip this.
We have actually a structure
that move on. But what we really also found was that the training was complex. It was very rushed. And there were pieces that were missing a little bit. Actually, Cindy, you asked about the if we had fidelity measures with the implementation. We did. And they were goodish measures, but they could be improved upon. And I'd actually like to turn the floor over to Michaela, who was one of the coach trainers, and she has picked up this baton about the coach training and really looked at how, even though it was perceived as strong, she's really looked at how in her dissertation research, she can strengthen that training. So I'm going to pass it over to her.
Thanks, Veronica. Before I do, there's one more question here asking, how did we assess the training sessions? By questionnaire or just coding the recorded video? I'm not sure I fully understand. Nilufar, do you want to elaborate?
Yes.
Yeah.
Can you hear me?
Yep.
Yeah.
I want to know that because you mentioned that you coded the video, I want to know that how because you had two types of training, I want to know how to access both of them.
Yeah. So actually, Nilufar, I think you're really talking about that question. It's about research that might be conducted in a university setting, like to record all of the coach trainings across 26 different organizations, or even the screening, and then to code that video. That would have been, I mean, we already had too much data. It would have been just impossible. We did not code the training per se, or collect data on the training. we counted on the expertise of our highly trained coaches. So in a university controlled, researcher controlled, you might have done that, but we didn't have the resources to do that in this study. Does that help?
Okay, I got it. Yeah, thank you.
Yeah.
Okay. So as Veronica said, I was one of the coach trainers and was very impacted by the PACE project. I really enjoyed the experience for many reasons, both as someone very interested in research, as well as an early intervention clinician myself. And so I did pick up, as Veronica said, on some of the themes that came out. I had a bit of a different perspective because I was one of the trainers. I wasn't on the research team, but of course I was interested in research. And the thing that became really clear was the complexity, as was alluded to, right? It was a really big training endeavor to train people in the Early Start Denver model in a really short amount of time, and then train them in this completely different thing, parent coaching, and then merge the two together. And what was clear to me was that a lot of the early interventionists who struggled, I felt like they really struggled with the NDBI, with the Early Start Denver model, but they actually had really strong coaching skills. But because they were meant to be coaching in this NDBI, they had a hard time having nice outcomes as demonstrated by these fidelity measures that we were using. And so I kind of mulled on this and talked about it with anyone who would talk about it with me, and came up with these research objectives, which seem quite lofty as identified by my candidacy committee. However, it felt very much in my wheelhouse because this is something that I really I love to do. Talk about parent coach training. And so I set out to develop a parent coach training program for early intervention providers without any attachment to a particular type of model. So without an NDBI. So looking at anyone who works in the field of early intervention across disciplines, regardless of what, the diagnostic reasons that they're seeing kids for. So just about parent coach training. And then to implement the parent coach training program with a team of early intervention providers regularly working with families, and then to evaluate the effectiveness of that parent coach training. And so I also learned from PACE, as Veronica talked about earlier, that one of the participants, who was actually one of my coach trainees that I got to work with, said it's like we're building the car while we're driving it. So there was a lot that we, like even some of the fidelity tools, we were sort of refining them as we were. So we had them set up, but they weren't completely ready to go as we were doing the first two phases of training. So the trainers almost didn't know what it was they were shooting for, which was really challenging. So I became quite interested in looking at these training models for professionals in clinical competence. And I came upon something called Miller's Pyramid of Clinical Competence, which actually comes from the field of medicine, that was first published in 1990. And I've come to know a lot about it, and a lot of medical programs all over the world are really built on this particular pyramid. So at its sort of simplest level, it's very much just about giving foundational information. So just that basic, in medicine, it would be anatomy, physiology, those types of skills, getting that into people's heads, and then within that building on learning what to do with that information in clinical practice. So there's this heavy knowledge transfer piece of information. And then that third level that shows how is very much about practicing. So practicing with support, which, as we found out in PACE, was really helpful to clinicians, which makes sense. As Veronica said, they had a lot of time to practice with support, even though some of them still felt it was not enough. And then within that practice, then moving into that demonstration of clinical competence. And so, Veronica, if you want to move it into the next slide, you can just do all the things. there's a couple. Yeah, there you go. So within that model, a really big piece of Miller's model, Miller's pyramid of clinical competence is this idea of assessment. So assessment of learning, which is something that we're all familiar with, right? So taking a look at, for example, baseline scores, and then do some follow-up testing to see if there was change. But this idea is sort of this orange that's in the middle of the pyramid here, this idea of assessment just simply for the purpose of learning. So assessment for learning without a lot of heavy weight on it, allowing people to move ahead or move through, but just an opportunity for people to think through, did I actually learn the concepts at various levels, at level 1, 2, 3? And if not, opportunities for self-reflection and thinking about, okay, what do I need to learn differently? So that was something that I really took when I was building this parent coach training project. And so there was lots and lots of assessment opportunities that I put all through the different levels as I thought through sort of these parent coaching concepts. So with regards to that level 1 and 2, it was, as Veronica said, COVID, so online learning felt very realistic. So I had the opportunity to partner with one of the agencies that was part of PACE. And I'm so grateful to the trainees that I worked with on that team, who just became champions of parent coaching. And I've maintained, professional and relationships with them. And they really wanted to get their peers trained up in, interestingly, not the NDBI, but the parent coaching, the process of supporting parents this way. And so I connected with this team, and in fact, Denise Watson, who you saw talk a little bit about the impact on her staff. She was the management, so she's the person that I'm working with at the executive level at an agency in Island Health, but I don't actually live in the same community as them. We live a few hours away. So all of our level 1 and 2 training has been online. And essentially, we did 8 2-hour online lessons, kind of working through this level 1 and 2 information. And so it was very much just about these foundational underpinnings of parent coaching, coaching characteristics. What does parent coaching actually look like? And we did lots and lots of video examples. And throughout that, so after each online learning lesson, there was this opportunity for assessment for the purpose of learning. So they had online quizzes, which they knew really did not matter how they did on those quizzes, and they were able to see the answers to those quizzes after they had completed them, to give them that opportunity to self-reflect and think through. And then we had some time just built into that, to those lessons, to talk through concepts that didn't seem to be resonating. And as much as they hated the online quizzes, some of them have said things like, oh, like it did actually impact my learning. I did realize that I wasn't fully understanding that concept until I took the quiz. So it was like, I feel like I'm seeing Miller's model, Miller's pyramid come to life in front of me. So I'll very briefly go over, because I know, oh, I think there should be one more in there that might be animated, Veronica.
Okay. Great.
Yeah, there is. Yeah. There's lots of early intervention providers here. So just quickly, that some of these foundational concepts that we've covered in levels 1 and 2 is sort of this idea that, family-centered practice is what I think a lot of us who work in early intervention, rest on. It's something we've all learned about, and being in the fields that we're in, we've bought into. But what became clear, and there's some nice research to support this idea, that we don't quite know how to operationalize these principles and beliefs in family-centered practice. And that is really something that coaching does nicely. So we revisited what family-centered practice is, what it looks like. And then we drew on these two, I would kind of put them into the theoretical realms, looking into the work of Malcolm Knowles around andragogy and those adult learning principles. So really identifying what those are, because really, the practitioners are working with parents, so working with adults, so really getting at what is their motivation for engaging in this early intervention with this practitioner. And then that second theoretical piece was drawing on the work of Carl Rogers from psychotherapy, and really, how do we create a safe space for learning for these parents? Because it's quite vulnerable to be trying things with your child, in particular, if they feel like, oh, you're the expert speech language pathologist. I don't know how you do what you do. So it's trying to create the safe space so that they feel comfortable sharing with the, early intervention provider what it is that they are doing with their child, and figuring out, using those adult learning principles, how can we teach them at their level, at their, zone of proximal development. And then there's those two types of expertise. So the parents' expertise on their child, where is their current knowledge at? What is it they want to learn? And what is it do we need to know about their context, their family circumstance, the variables that are going on in their home, in their daily life, etc. And then pulling on our expertise. So yeah, Veronica's hurrying me up now, so that's fine. I could go on and on about that. It's the thing I love a lot about. And then so we finished the level 1 and 2 training, and this is where we're at right now in the project. We're at the practice phase. And so each coach has self-identified 3 practice families. That was something that was very, very different than the PACE project. So essentially they have understood a little bit about what parent coaching is, and they've decided on goals that they're going to work on, families that they're going to work with. And then so they've practiced setting goals, practice coaching, and they have been video recording. This kind of gets at that video question, all of their parent coaching sessions. That was also a learning from PACE. As Veronica said, the technology was challenging. Yes, we've come a long way, but recording yourself on video is hard, and people don't like to do it, and they don't want to do it. And so in order to try and capture as much data as I could, and to have data to pick and choose from, and coaches to be able to decide which videos they want to sort of put forward as, here's an example of me coaching. They are being instructed, they have been instructed to record everything, and they're doing it. It's great. So they're video recording, and then there's lots of competency coding that we're doing. And then, so stay tuned for that level 4, where they're going to put together a package showcasing what they feel is their best work, demonstrating themselves, engaging in parent coaching. And then there will be, again, so remember that assessment piece for learning of learning, there'll be a final assessment of learning to look at as compared to their baseline scores. And there was a time to point of assessment as well at the end of level 2. This is what is coming down the pipe for me.
This is what Michaela's doing all summer.
There's
data analysis.
So much data, way more than I need to answer the research questions, because I love this stuff, but I am really overwhelmed by what's coming. And I'm going to pass the baton back over to Veronica, who can link some of the findings.
Yeah, did you want to talk about the preliminary findings at all? Anything?
I mean, the main thing is I can sort of comment on time 1 versus time 2 scores, which was some assessment practices, and there was definitely a jump. So if we kind of aggregate everything, which is, feels quite high level to do, but we sort of, if we look at their baseline scores, we jumped from 38% to time 2, which was taken at the end of level 2. So before they started their practice, they jumped up to 73%. So stay tuned for time 3. So that was kind of the written piece. And then the videos, we started with very low baseline scores. So the instruction at baseline was just to take a video of yourself engaging in family-centered practice. And so we started in the 20s, the low 20s percentiles. And we've got coaches at various trajectories with their practice. Some of them were super keen and they jumped right in. And so there's a couple who I would say, while they're still practicing, they have absolutely demonstrated the skills. They're well over 90% in their final videos or their most recent videos. Whereas some of them are slower. They're slower to practice, so their video scores have not changed much. But I would also say that there's some implementation barriers with regards to just timing and buy-in and willingness to really engage in the practice and shift that behavior.
Okay, so the things we learned from PACE that have informed Michaela's now future work of this is that we do need really clear, simple implementation plans, and they need to be doable in these complex community contexts and maybe more incremental. We took on a lot with PACE. There was a lot of change, a lot of positive things that happened as well, and it was a lot. What we are learning really in the places that continue with PACE and PACE-like activities, they have implementation leadership. They have people that are champions for these practices, and we do need more contextual supports to change practices in community settings. And these communities of practice really need to link with each other too, across the province of British Columbia, probably in Alberta as well. And we, in addition to implementation training, we need funding for that support to support implementation changing practices. Yeah, so that is all, but I will stop sharing and